I'll give you the. All right, so I'm talking about pelvic and lower extremity trauma. A couple of you guys that don't know some of my medical students. My name is Nels. I'm one of the newer associate attendings, and I really love taking care of trauma patients. I just finished my residency in New York at the level 1 domain trauma center in Manhattan, and saw a lot of trauma. And I think trauma management is really fun, actually, and it's not that it's easy, but it's straightforward. It's a matter of knowing what to do and doing it, and not dilly-dallying, but just knowing the next step and going after it. So I'm trying to just, I want to present this in the format of just some cases and have it be kind of open where we can discuss them. Feel free to ask questions or disagree with me, or if there's any input from the faculty, by all means, have it be an open forum. So these are all cases that are real cases. Most of them are ones that I saw. And so this case, first one, 35-year-old motorcyclist riding his brand new Ducati in New York, going 60 miles an hour down 14th Street. Car pulled out. He hit the car, brought out the car. Basically, they did a U-turn right in front of them. Brought in, and he was hypotensive. His blood pressure was 70/40. His heart rate was 130. Had multiple abrasions over his chest and abdomen. So I want to talk through really quickly kind of the trauma resuscitation steps. You guys just took ATLS. What do you guys want? How do you go about this?
A, B, C, D, E, F.
Yeah, exactly. Exactly. It sounds kind of silly, but that's exactly right. So first of all, look at their airway, and if the airway is not protected, then you need to intubate them. And the B for breathing, if he doesn't have breath sounds on one side, you need to put in a chest tube. C for circulation, what's his heart rate, what's his blood pressure, does he have pulses in all of his extremities, and D, disability, which is GCS. If GCS is less than 7, he's obtunded, he's not protected the airway, needs to be intubated in that case as well. And then E is exposure, and this is super important, and I find that it's often not done. Even here, there's sometimes look at these trauma patients, and we need to do an assessment, and you go to see them and they have their pants on and their shirt on, and you can't do an assessment really if they're not fully exposed. So in all these cases, really important to fully expose people, especially in this gunshot wound or stabbing, to look at them over head to toe, look at their axilla, look at their perineum, look for another sign of injury, and then F for the fast exam. So this guy, concurrent with doing your ABCs, you need to get large bore IV access, get him on a monitor, so have 2 18 gauges, keep giving him crystalloid fluid resuscitation as he's hypotensive, and then the fast exam. And what we do in trauma center, in my background, we would do a log roll, which I think they teach in ATLS, palpate their spine, and then do a portable chest x-ray. And in this scenario, someone who's hypotensive with trauma, I need to get a portable pelvic x-ray as well as part of the trauma resuscitation. So this patient, he had a normal chest x-ray, and his pelvic x-ray was this. You see here, he's got one of those wide pubic symphysis. It's like an open book pelvic fracture. So I'm talking about pelvic trauma. I'm going to run through really quickly talking about the different types of pelvic fractures. There's a bunch of different classifications, which I do not think are important. I just took the boards like 2 months ago. I'm relatively aware of what was on them and passed. And also you guys have the in-service, I think, in a month or two. So I'll try to kind of talk about stuff that I think is important as far as knowing for those tests. So really, for pelvic fractures, what's important is to know, is it a stable or an unstable fracture? So this is the type 1 fractures, they're just avulsion fractures, where usually one of the insertion points of a muscle pulls off. These are stable fractures, they're treated non-operatively, conservatively. These are the type 2 fractures, they're called single ring fractures, where the pubic rami or iliac wing, these are also stable fractures. However, sometimes they can be associated with a GU or visceral injury. Now, the more important sort of pelvic fractures are the unstable fractures. They're called the double ring fractures. So the open book fracture, like this patient had, is the most common pelvic fracture in motorcycle accidents. It usually occurs from an anterior-posterior compression force. So if there's a deceleration or a crush injury, it disrupts the pubic symphysis and can disrupt the SI joint. Now, these are important for 2 things, that they're unstable, and that can be associated with GU and visceral injuries, but more importantly, they can be associated with life-threatening hemorrhage from the arteries and the pelvic vessels. So these need to be immobilized. They need to get orthopedic consult for external or internal fixation. And most importantly, though, need to assess for a sign of a vascular injury. So here's some other pelvic fractures. That can be a vertical shear fracture like this. This is more in a fall. There's also can be acetabular fractures where the acetabulum, where the femoral head attaches, it can be shattered, or lateral compression fracture where the whole iliac can be shattered. So recapping our patient. So when you're assessing the patient, you're doing the primary exam, you're going down kind of head to toe, ABCs, palpating the chest, palpating the abdomen. When you get to the pelvis, you need to assess it for the stability of the pelvis, basically by taking the pelvic wings and sort of rocking it. And in some cases, you'll feel it, the pelvis is unstable. This patient also, we have the X-ray showing he has an open book pelvis, so this person needs to be put in a pelvic binder. So the binder immobilizes the pelvis, and theoretically kind of will tamponade it. They have a bleeding vessel in the pelvis, will theoretically tamponade it somewhat. I'm not sure we have pelvic binders here, but I'm sure, I'm at the trauma center, I sort of played around with them. Some of them are a little bit tricky the way they are secured, but they need to be put on and be put on pretty tight. So you need to know how to put on a pelvic binder. So a lot of trauma is based on algorithms. So this is, sorry, it's a little bit off the screen, but this is kind of the treatment algorithm for someone with a pelvic unstable patient with an unstable pelvis. So first thing you do, put on the pelvic binder, and then look at their hemodynamics. So their hemodynamics stabilized. And this patient, in my example, we actually fluid resuscitated him, got his blood pressure up, he was looking okay, so took him down and did a CT scan. Scanned his hand scan, basically, head, chest, abdomen, pelvis. His head he had nothing in his head, nothing in his chest, nothing in his abdomen, had a bleeding vessel in his pelvis. But going straight down the pathway, if they have any intraperitoneal bleed, if it's a positive fast, or they have external hemorrhage, that patient would go straight to the OR. If they do not have those things, but still have a pelvic fracture, unstable pelvis, they would go directly to the angio suite for hopefully you have IR available. These patients, if they have a bleeding vessel in the pelvis, going to IR and getting embolized could do really, really well. If you don't have IR available and they have a vessel in the pelvis that's bleeding, they go to surgery. They do quite a bit more. It's a really difficult surgery. It's difficult to access the retroperitoneum. They have to pack the pelvis. They don't do as well. Ideally, having IR suite, having IR available quickly is a best case scenario. So this is an angiogram of the pelvis. It's the larger area is the internal iliac, and then I believe it's the pudendal artery is the broken arrow, and you can see that there's extravasation there. So that's what this is an old style angiogram. Most centers today will do a CT angio, which will look similar, but you'll see a blush if there's a bleeding there. Most common and most significant bleeding artery is usually the internal pudendal, which can be damaged, usually with posterior pelvic fracture. So this patient, actually, we scan scanned him. He had a bleeding vessel in the pelvis, took him to IR, got embolized. He actually did great. Next day, he was back, basically being a jerk. But he saved his life there by taking him to IR within about an hour of him arriving in PD. So that's pelvic fractures. We'll talk really quickly about some associated injuries that you can have with pelvic fractures. The first one is a bladder injury. The most common sign of bladder injury is gross hematuria and suprapubic pain. It commonly occurs in patients with widening of the symphysis pubis or of the SI joint. This is on a fast exam, looking at the bladder, and they have a collapsed bladder with thickened wall, and you can see there's a defect in the wall of the bladder, and there's extravasation of urine. So a bladder rupture can occur when there's a full bladder and there's direct pelvic trauma. If this is suspected, you have gross hematuria, you can do a CT cystogram, or you can do a retrograde urethrogram, which can also show that there's extravasation of contrast into intraperitoneum from a bladder rupture. If there's extravasation, these need to be repaired emergently. The other thing that can occur is urethral injury, and the clinical presentation of urethral injury is on rectal exam. There can be a high-riding prostate, and there can be blood at the urethral meatus. So usually it occurs at the junction of the membranous and vulvar urethra, and is associated with inferior and superior pelvic rami fractures. These you can assess for the patency of the urethra with a urethrogram as well. So here's an anterior urethral rupture. You can see the yellow is there where there's extravasation of urine or contrast in the scrotum around the penis. These can occur also with direct blow to the perineum. So I saw once a patient who was just riding a bicycle, went over the handlebars, basically hit his perineum against the stem of the handlebar and had a urethral injury. It can also occur with a penile fracture or with trauma. I've heard about people putting like those glass martini stir sticks in their urethra for whatever reason, and having a urethral disruption like that you'd see on a urethrogram. These need to be repaired because if they're not repaired, they can get fistula or stricture. And there's also posterior urethral rupture, more proximal to the bladder. These are more associated with pelvic fractures, and these will extravasate adjacent to the bladder. These are important to repair because you can get impotence or incontinence secondary to these. So here's a normal urethrogram. You see the contrast going through the urethra to the bladder. Here's one that's extravasating due to a bladder rupture. One thing to know about, I doubt you'll ever do, but was on the boards. It's called a suprapubic cystostomy. So if someone has severe GU trauma and have a distended bladder, or if they have a burn or severe urethral stricture, basically you can do an ultrasound-guided cystostomy with a Seldinger technique to leave the catheter in place. And the contraindications are if the bladder is collapsed, or you can't visualize it because you have a really high rate of bowel perforation when you're doing this. So just something to keep in mind with this suprapubic cystostomy. So let's talk for a second about other GU injuries. From testicular trauma, usually blunt or straddle injury, usually presents with edema, ecchymosis, and tenderness, may or may not have hematuria, and usually you can just evaluate this with an ultrasound to see if there's hematoma, can develop a hydrocele. In some cases, it can develop an abscess after trauma. And this is an example of testicular hematoma and ecchymosis. Renal injuries, just to complete kind of the GU system, really quickly can occur with penetrating or blunt trauma or with lower rib fractures or transverse process fractures of L1 or L2. And these are really important to identify because if there's a renal injury to the, or a vascular injury to the kidney, you can get ischemia and basically lose a kidney really easily, and they have to be revascularized within 12 hours to maintain their viability. And so this is a CT series. So this is the arterial phase. You can see there's a little disruption in the wall of the kidney. That's the venous phase, and that's a delayed nephrogram. So there's some delay, and then they rescan. You can see there's extravasation of contrast. So if you're concerned about there being a renal injury, you need to get a delayed series. The delayed nephrogram, you can see if there's contrast extravasating and needs to be repaired. Okay, let's go into another case. So a 75-year-old female fell onto her left side. She was unable to ambulate or bear weight on her left side. Her leg is shortened and externally rotated. You guys thinking? Yeah, so you get an X-ray. This little old lady, and this is her X-ray. She's got some osteoporosis, a little bit of joint space narrowing, a little bit of arthritis. I don't see any fracture here. What's your next step? Still not able to ambulate. Exactly. So you go to CT. This is her CT as well, which is kind of most pertinent view. No sign of fracture. So this patient was still unable to ambulate. Ended up getting admitted and getting an MRI. And this is her MRI. Same hip. Look at this. She has a pretty good size intertrochanteric fracture. So I bring this up to say that hip fractures can commonly be missed on plain films and even can be missed on CTs like in this patient. And if someone's continuing to have a significant amount of pain and unable to ambulate, still you have clinical suspicion, then you may need to get an MRI.
So in your practice before you were here, did you guys do that stepwise kind of thing? Because typically we always get one way or the other from orthopedics. Yeah, we got to do an MR, and some people say, no, you can do a CT. So I usually end up just going with an MR because I've missed them on CT, like you said, but I didn't know if there's some sort of standard of care in your mind or common practice.
That's probably the right way to do it. In my experience, has been into getting a CT, and then it was much more difficult to get an MRI. But thanks for that example, because that's what I'm trying to bring up. I'm trying to tell you guys some teaching points I think are interesting and important to know, not just a straightforward like, oh, this is a hip fracture. Know that you can be missed on a CT, as Dr. Kohler said.
Yeah. So in general, I think in our practice here, that you don't get much pushback for doing an MR in these patients with an occult, the non-ambulatory hip trauma that you don't see, and you're ruling out an occult fracture. It's only if there's going to be a contraindication to CT, hardware in their body or something that won't allow you to do it. But most of the time, our institution's pretty reasonable at getting MRs in these patients, and the orthopods usually want it. So.
And in your test, it's going to be, actually thing is you'll show that what's the next step, you'll have CT, MR, the answer could be MR.
Right.
I looked at a case series. There's 100 patients who had hip trauma, had negative plain films. Of these, 46, they all got MRIs, and 46 of them had femur fractures. So,
just to clarify, so you said in textbook the the next step after an X-ray is MR?
Yes.
Okay.
And these are just some common hip fractures in elderly patients. Usually it's an intertrochanteric fracture. In younger, healthy patients, it's usually a subtroch fracture with a high force of energy. And complications can be aseptic necrosis, secondary to a femoral neck fracture. Okay, so let's go on to another case. This is a 7-year-old male with right hip and leg pain after falling while skateboarding. It's a real case. Unable to bear weight or ambulate due to pain in his right leg. And this is his, this is what he looked like. So you got an X-ray. What do you think about this one now? Yeah. Which way is it? What's that? What's the most common dislocation? Hip dislocation. Yeah, exactly. You know, in most cases, it's posterior hip dislocation, usually from direct force. It can occur in car accidents, also when someone hits their knee against the dashboard, it can cause direct force. Most of the ones I've seen have been in prosthetic hips, but it can occur with a native hip as well. Usually they'll be internally rotated, flexed, abducted, and shortened. These need to be reduced as soon as possible because they can cause nerve damage to the sciatic nerve. Also could cause avascular necrosis. There's also inter-hip dislocations that are uncommon and usually present with the groin mass. These are even more important to reduce because these have a higher rate of vascular and nerve injury. This is another view of the posterior hip. And then really quickly,
rapid response.
It's a whole different talk, but as far as reducing hips, has anyone tried this Captain Morgan technique for hip reduction?
I've seen it. I haven't done it.
Saw it done the other day.
Oh, really?
Yeah,
Was it successful?
It didn't work.
Attention.
It hasn't worked for me either, to be honest. But people like on blogs are talking about this a lot. I think, but in my experience, giving sedation, usually with propofol, gets someone deeply sedated so that they're able to relax the muscles. I've tried doing a nerve block, got good anesthetic with the nerve block, but I wasn't able to get enough muscle relaxation to get in. Have you been able to reduce many hips without doing conscious sedation?
No. Yeah, don't try. I mean, the hard part is all these people are old, and so you always get a little. This guy, this was Bonason's case actually a couple of nights ago. This guy was 85 years old, and they wanted to reduce his hip and the ED, and he was a prosthetic hip that was out, which are notoriously tough. And you looked at the X-ray, and this thing was way out. So we got him down. We didn't use propofol because he had gotten a lot of narcotics, so we gave him etomidate, which I used for a lot of reductions, and it was great. And knocked him out, and the sedation was fine, but he couldn't get the damn thing in. And we tried this, then he tried, breaking his back, lifting up. I mean, this is not an easy thing to do.
Yeah.
So
I've found the best success with good sedation and then kind of the older style, just standing on the bed, straddling the patient, trying to use your knees instead of your back to distract them. But moving on, this is really quickly mid-shaft femur fractures. It's like radiology 101 for like special class or something like fracture. Like, no kidding. So just talk really briefly about complications of mid-shaft femur fractures. Keep in mind that these can bleed a lot. You can bleed up to 2 or 3 liters into the thigh. So in trauma, basically, if someone's hypotensive and you believe it's hemorrhagic shock, not spinal shock, there's really only 5 places someone can bleed. They bleed into their brain, they can bleed into their chest, they can bleed into the abdomen, retroperitoneal space, they can bleed into a long bone space, or they can be bleeding exteriorly. So, if you go down the list and consider, so someone with a long bone fracture can actually bleed a lot and can present hypotensive and hemorrhagic shock. Just keep that in mind.
Artery.
Yeah. Yeah, exactly. And because there's a large potential space, is what I wanted to bring up there. Usually these will come in a long leg traction splint, and this is to try to prevent neurovascular injury. So let's move on to another case. So a 38-year-old male presents after a motorcycle crash, complains of pain and swelling to the left knee. He's unable to flex the knee due to pain, and he's unable to bear weight. And this is what he looks like here. This is a real patient. What do you guys think about this? Yeah, exactly. So these are relatively rare. So this is a posterior knee dislocation, but they do occur. And the thing to know with these is that there's a really high rate of popliteal artery injury, and 100% of these need to get a CT angio. This is something that's on the boards that they need. They can have a delayed presentation as well. A lot of them reduce spontaneously, but they can have a delayed vascular or neurovascular injury.
Yeah, that's one of the things with those can be tricky in a person who comes in with a bunch of injuries and multi-trauma and their knee looks okay. It's just swollen and stuff, but you have to be very suspicious, especially in motorcycle crashes, because they have dislocated.
And
Because
reduced.
I've seen them auto-reduce as well.
Mm.
But usually when that happens and they auto-reduce, it looks like a nasty-ass knee. I mean, it's really swollen, really
Okay.
ectomotic. So have a very, very high index of suspicion for a dislocated knee.
And there's a pretty cool video on YouTube of reducing these actually. And basically what you do is you can use one hand on the distal femur and then distract with your other hand and basically just with distraction, get it back in place and put them in a knee immobilizer, but you need to assess. The reason I bring this up is CT angio to assess for vascular injury or popliteal artery injury in the knee dislocations.
Just to clarify, you're doing the CT angio after you reduce?
Yeah, exactly. Okay, another case, a 21-year-old male presents with a gunshot wound to the right lower leg. His heart rate is 110, his blood pressure is 110/70, and this is kind of roughly what it looked like. So with an isolated gunshot wound to the knee. So in this case, I would go down all of your APCs, fully expose the patient, look at their axilla, roll them, look at their back, look at their perineum, make sure there's no other sign of injury. But how do you go about evaluating this patient? Hey, Ryan.
Well, I would get an X-ray to see, like, you can see where the bullet is, and I will get a history, see how many shots there were, I guess. And if you think it's just one shot there, get an X-ray of the leg, try to evaluate where the bullet went, maybe if it fractured one of the bones.
Yeah.
You treat it like an open fracture.
Yeah. Well, so the first thing you want to do is look for signs of vascular injury. Check their pulses, but do an ABIs. You guys know how to do an ABI? This is something you really got to know how to do for if there's a penetrating trauma to the extremity. And this is the ankle brachial index, looking for arterial injury, essentially. And the way you do it is use a blood pressure cuff and a Doppler, and you check both upper extremities first, and you use whatever the higher systolic number of the upper extremity. So just like taking manual blood pressure, inflate the cuff, and then deflate it, and using the Doppler until you get a Dopplerable signal. And then you'll get the systolic pressure, and then compare that to the affected extremity. So say there's in the right foot, like this guy had an injury in the right leg. So the highest pressure in the right foot, where you get the systolic pressure over the highest pressure on one of the arms, is the ankle brachial index. Is what people use, for peripheral vascular disease to see if there's arterial insufficiency. So in those patients who have arterial insufficiency, it's not accurate. However, in someone who does not have arterial insufficiency, a young healthy person with gunshot wound it's 95% sensitive for vascular injury. So an ABI of greater than 1 is normal. Between 0.5 and 0.9 is indicative of injury to a single arterial segment, and an ABI of less than half, so this is thought to be less than half of the upper extremity, is indicative of a severe arterial injury. So this is something you really got to know how to do, and this is really the first step in evaluating for penetrating extremity trauma. So here's in Tintinelli, this is the algorithm for penetrating trauma. The first thing you do, history and physical, and then document Doppler pressures. And then from there, separates into there's hard signs of vascular injury or soft signs. And so what they determine to be hard signs are if there's absent or diminished pulses, there's obvious arterial bleeding, if there's a expanding or pulsatile hematoma, if there's a bruit, an audible bruit or a palpable thrill, or distal ischemia. Those patients need to get an angio or get a surgical exploration. If there's soft signs, and what they determine as soft signs are a small stable hematoma, injury to an anatomically related nerve, there's unexplained hypotension, which doesn't seem like a soft sign to me, or history of hemorrhage. Those people can be observed, and these people probably need to be observed for a period of time to make sure there's not deterioration of their Doppler pressures or they develop hard signs of injury. I would have a low threshold for doing a CT angio on any of these people if it's near a neurovascular bundle or an anatomically significant artery or nerve. So specifically an artery, you need to get a CT angio. Yeah.
Realistically speaking, any of the attending here, would anyone do this? Like, I don't know, in the trauma bay, I just feel like if there's a pulse or not, and then you do an angio. I don't know, would anyone actually, like, get the cuff and the Doppler going?
Yeah.
Did?
Yeah, the nurses really good for pain, because a lot of them, it would just be, you could do a pulse, they would get heavy trauma, and then even if there isn't an angio at all, so they didn't do anything, do an angio.
I know that I've seen a couple of cases of that. We don't see that much like this, but the last one we had, they immediately went to a CTA, did the CTA, and no hard signs. So they just did the CTA because it was
I think in most places would I think CT angio is so common and is diagnostic modality of choice in most of these things. So, for example, at Bellevue where I was, when we had a protocol, pan scanned most people with, and were protocol if there was lower extremity trauma to get a CT angio of the lower extremity. So I think you're right that most people, but I think it's, I want to mention the ABIs because it's an important part of the algorithm, and it's important to something to know, and to do. I've actually done it. We had a case where we had four 17, 18-year-old kids who were all shot in the legs, and we couldn't take them all to CT, so we actually checked the ABIs. I think it's something important to know, and probably most of them
Definitely
about CT
important to know.
angio.
I just did, I wanted them to know, realistically speaking, like, I don't know, pulses is usually like the most common in the trauma bay when they go to
Yeah.
trauma.
Yeah, and as I said, the heart, one of the heart signs.
Yeah.
And then as far as Ryan was saying, so they need to get an AP and lateral of the location of injury. It's important to know to get image above and below where there's a trauma. The reason being that there can be embolization of one of the bullets. So this is somebody's shoulder, obviously shot with a shotgun. So imaged the joint below, and they had some arterial embolism of some of the pellets down into the sporn. Interesting. And then if there's joint capsule involvement or bony involvement, specifically, you need to treat it as an open fracture, treat them accordingly. They need to go to the OR to get washed out, need to be covered with antibiotics, genital plus a cephalosporin. All right, another case, and we've got about 10 minutes left. So this is a 15-year-old girl. She decided to go out for a cross-country team at her high school, so she started practice with her team mid-August. After a couple days of workouts, she went to her coach complaining that she had pain to the anterior shin, and he was saying that she probably just had shin splints, that she needed to keep running. As the workout progressed, she got more and more painful to the point where she had to stop her workout. The pain got worse overnight, so she came into the ER the following night. On the exam in the emergency room, found that her leg was red and swollen. The anterior of the leg is very sensitive, palpation, and felt hard and warmer than other parts of the leg. Dorsiflexion of her toes was limited by pain, and her DP pulses were weak, and she had some sensory loss of her first and second toes. What's this one's? Yeah, it's Cameron.
It sounds like compartment syndrome.
Yeah, exactly. So this is something really important to recognize, and especially in setting a fracture. I would recommend when you're examining someone, say a fracture of the tibia, to document your exam of the joint above and below, and also document that the compartments are soft. Check by palpating the compartments. Can occur with a crush injury or with trauma, or in the absence of trauma, like in this patient it can also occur with rhabdomyolysis, with prolonged compression. Read about if there's a high pressure injury, someone with one of those compressed air paint guns, shot some paint into the finger, went up into the arm, and ended up getting compartment syndrome in their forearm. But the most common is secondary to a fracture, usually the proximal tibial shaft. It can also occur with distal radius fracture, but the proximal tibia is the most common. And you see there's four compartments there: the anterior compartment, the lateral, the deep posterior compartment, and then the superficial posterior. And the most common it occurs in the anterior compartment. And you guys know the cardinal signs of compartment syndrome? What's up? Yeah. Yeah, so pain, pallor, paresthesias, paralysis, pulselessness. And what they ask on the boards is actually what are the early and late findings. So everyone should know the P's, but what's an early. So earliest finding is pain. The late findings are pulselessness and paralysis. If you got to that point, you missed the boat. Irreversible damage occurs in 4 to 6 hours, and treatment is a fasciotomy, so it needs an emergent consultation for a fasciotomy. And the diagnostic tool is using the striker needle to measure compartments. Less than 30 is normal. Above 40 is an indication to go emergently for a fasciotomy. I've never actually used the striker needle. Have you guys ever?
Not here. I'd use it in residency.
Okay. I think usually if you get the consultant involved, you have a suspicion, or get the consultant involved, they'll want to check the pressures themselves. And usually they'll be the ones who check the pressures. But earliest symptom is pain. That's what I wanted you guys to remember.
Do we even have those?
Mm-hmm. Oh, I'm sure we do.
Ortho has them.
Yeah, ortho. Yeah. They're worried about a compartment, at least here, worried about a compartment syndrome. Make sure you talk to those guys, take a look, but do it with them, learn how to do it. Sure.
So like in the ED, if it's like after an injury, I mean, like we had one case with my ECSD just working as a student. But I mean, this woman, she just had a wrist fracture, but she was in so much pain she needed to be wheelchaired into the room. I mean, gosh, that's going on. And ortho saw her, she's okay. I mean, her pulse so they were compartments in
Hmm.
the refrigerator OR. But I mean, the sign was basically just ridiculous amount of pain for her.
Did they measure compartments before?
They didn't, no.
They relied on her pulses. Bad.
Something to know. I'm sorry. Dave.
I was just gonna say, ortho always is like, oh, it's not compartments.
Yeah, they blow it off a lot.
Everywhere I've been. So a couple of things about the striker. You just, I mean, have any faculty, has anybody actually, at any of their previous sites, is it something that's in your skill set?
Only when the ortho guy was helping me do it. I just wanted to learn how to do it.
So that's,
It's
I mean,
not-
that's it.
I mean, I suppose when you're in rural areas, you guys are gonna practice in the middle of nowhere, you might wanna know how to do this. But usually this is the purview of the ortho.
So everywhere I've ever worked, not just here thing, it's ortho. You call them, and then there's always this battle of, it's not compartment syndrome. Get out of here. And it's everywhere. It's always a bit of a fight.
And something to know is the tenderness has to be along the entire compartment. So if it's in the lower leg, the tenderness should be along the entire leg, not just one isolated point, but it should be along the whole compartment. So if it's compartment syndrome, it's going to be tender.
Yeah, as Nell said, just don't be too happy if you can feel pulses. If the pain is out of proportion, what you see, patients got funky sensation, even if they have pulses, don't blow it off.
So did you say what a normal compartment
It was less than 30.
All right. So I mean, what kind of pressures do you need to lose pulses?
Systolic.
Right, systolic pressures. I mean, so loss of pulses, just because they come down and feel they have pulses and go, it's not. I mean, okay, fine. So the pressure's not 100, and pressure's not over 100. Okay, fine. So I mean, that's the last thing to go generally, just before you lose the limb.
So another case, a 75-year-old female who fell striking her right knee 3 days prior, now presents with swelling, pain, inability to bear weight. This is what her knee looked like. So you got an X-ray of her knee on the left. You see she's got a little proximal fibula fracture, but that doesn't explain. You wouldn't expect that degree of swelling and pain. So this patient got a CT scan. On the CT scan, you see she's got a tibial plateau fracture. So the reason I bring this up is these are really a commonly missed fracture that high rate of litigation as well due to missed tibial plateau fractures. Something you need to keep high suspicion for someone with pain out of proportion to their exam or significant swelling like this patient 3 days after an injury. And it's commonly missed on a plain film, so really important when you're looking at plain films of the knee to look at the tibial plateau, ensure that it's smooth, there's no disruptions, and if they have persistent pain and swelling to go on to further imaging, usually CT of the knee. I also read some cases where people performed an arthrocentesis due to there being so much pain, and finding an arthrocentesis with a tibial plateau fracture is lipohemarthrosis, where there should be synovial fluid, which should be clear theoretically. There's a hemarthrosis, there's going to be blood, but if you withdraw fluid and look at and it's bloody, and look at it under the light and it has these shiny globules, that's indicative of there being fat from a tibial plateau fracture from the bone that's gone into the joint.
And a lot of it is exam. I mean, if that knee looks awful, you see how big that knee is, it's really painful. X-rays are not, it's complex enough to be clinical. Your suspicion.
Yeah, so you don't want to miss these. Usually it's direct trauma to the knee, but in elderly people, kind of all bets are off. They can fall, have a relatively simple fall, and have a tibial plateau fracture. But in younger
they don't
patients,
always look that bad.
Mm-hmm.
And if you make sure you look at the laterals as well, so you see the smooth edge on the anterior, make sure you follow it on the lateral as well, because you can get that little bit of a depression. It's older folks, and you don't think it's all that much on, and you can just pass it right by, so don't pass it right by.
And CT is actually less sensitive in patients with osteoporosis, and these older patients who have severe osteoporosis, the CT isn't as good as an MR. So you have, similar to what we talked about earlier, you might want to consider going to an MR in someone older if you're concerned about tibial plateau fracture. So keep this in mind always for knee fractures. One last case, 40-year-old woman tripped and fell while hiking. This is one patient I saw a couple weeks ago. Tripped and fell while she was hiking in Mount Woodson. She immediately experienced pain, swelling, and deformity of her right ankle, and she was unable to bear weight due to pain. She had been wrapped up in a towel or something by EMS. No one had uncovered her, and so I went in to see her, unwrapped her foot. This is what her foot looked like. Palpated her pulse. she had no palpable DP pulse, and she's telling me, oh, my foot feels like it's asleep. So what do you want to do in this case? Get an X-ray or ortho consult. So this is a real true emergency, and you don't need to call orthopedics for this. This is what ER doctors do. So basically, it needs to be emergently reduced. Grab your stuff to splinter. You can do a hematoma block, give them some fentanyl, and reduce it ASAP because you have a high rate of ischemic in limb, basically, because you lose the foot because she has neurovascular injury and needs to be reduced emergently. And you get X-rays later. So this is what that patient's X-rays were. Bad ankle fracture. All right, it's noon. That's all I got. Any questions?
I just have a
Comments?
sort of a comment. The first case, the guy with most of the pelvic fracture. One of the things that you're going to be guys seeing in the future is something called, I don't know, Reboa. Have you guys heard about this? Reboa, it's a resuscitative endovascular balloon occlusion of the aorta. So because the bleeding is in the pelvis, the only way the pelvic fracture is not very good. What they're doing now, and they've done this in England, and they're doing is they're putting in like an arterial femoral line and inflating a balloon in the aorta and preventing the basically ongoing blood loss into the pelvis.
Wow.
And they've done some, they're doing that aorta trial, which is ongoing right now, and basically it's increasing the survival of pelvic fractures. So it's a really cool procedure. It's like the new, only major trauma centers are doing it right now. So you guys will learn about it more in the next couple of years. But
It's a cross clamp of the aorta.
it's a way to prevent doing aortotomy and blood trauma.
I don't think they're doing it anywhere in town. I think USC is the closest place right now.
Oh, really? They're doing it?
trialing.
Interesting. Cool. Any other comments? All right.
All right, guys. Thank you. All right. So let's serve up a little lunch while we're getting set up for the